सो हेलो एवरीवन, कैसे हैं आप सब लोग। सो टुडे वी आर गोइंग फॉर इम्पोर्टेंट subject, that is the surgery recall from your recent FMGE examination. Okay, so these are PYQs which are very important. I request everyone to watch this video till the last, because here we are not just discussing the single question and its answer. We are discussing the topic, all the topic related to that question, all the options. So you will get maximum important points in the surgery by watching this video. So request everyone to watch the video until the last. And also one request to maintain a 21th notebook. Okay, so you already know 20 notebook, like for you knowing, but I request everyone to maintain a 21th notebook for the PYQ only, because whatever the 25 or 30 question asked in FMG from the surgery, almost 50 to 20 questions are repeated from the same topic from previous year questions, or from the same or repeated the same question. Okay, so it is very important to do PYQ for your any examination like FMG, INICET and NEET exam. Also I am also taking one video, or I am also we are also discussing the UPSC CMS exam questions. That's also very important. So before going into your NEET PG examination, do all recall of FMG, NEET and INICET as well as UPSC CMS, because these are also important. Okay, so let's start with the surgery discussion. आई टोल्ड यू टू मेंटेन नोटबुक फॉर PYQ, बिकॉज जब आपको सक्सेस नहीं मिलता तो आप क्या बोलते हैं कि मेरा लक नहीं था. सो द PYQs आर व्हाट यूर लक टू increase the chance of success. Okay, so let's start with the first question. The first question is, what is the common incision used for appendectomy? Okay, now you have to remember for the incisions for most of the surgery, important surgery, which incision is used for which surgery. Okay, so basically first of all, for the appendectomy we use most commonly we use the three incision, out of which one incision is most common, and that is what we have asked, and that is the McBurney incision. So three incision for the appendectomy. The first one is your McBurney incision, which is also called as McArthur incision, which is also called as gridiron incision. This is a oblique incision, and this is a muscle splitting incision. You can see here the first one blue, this is oblique incision, that is your the McBurney, McArthur or gridiron incision for appendectomy. It is muscle splitting again. The second incision, that is your second incision, this is transverse incision, and this is called as lance incision, which is also again a muscle splitting. So first and second are muscle splitting. The third one is your Rutherford Morrison incision. This is a muscle cutting incision. This is also for appendectomy. So out of these three incision, most common is your McBurney incision, which is answer here. Now other option, Kocher's incision. Where the Kocher's incision is used? Anyone know? Okay, this is in the open cholecystectomy. We use the Kocher's incision. Midline incision for the laparotomy. So we have to remember this all incision used in the surgery. Okay, now the next question is given image of lap appendectomy, and we have to mark the structures. So here is your scope. Okay, this is the what, this is a gallbladder which is upwardly push gallbladder. This greenish lines are cystic duct. This red is your cystic artery. This is your common bile duct, and this is the triangle called as Callot triangle, which to be dissected during the lap appendectomy. Okay, so this is image. So both questions are asked from appendectomy. Any doubt in this? Shall we move to the next? Okay, next question is, patient present in the OPD with the dilated tortuous leg vein. Oh, dilated tortuous leg vein, it will be varicose vein, right? No, you should read all the question, full question. He has history of trauma 10 years back on the same site, and there is a pulsatile vein. So likely diagnosis. वेरिकोज वेन में क्या होता है, डायलेटेड टॉर्टुअस लेग वेन होते हैं, लेकिन वेरिकोज वेन में पल्सेटाइल वेन नहीं होते. क्यों? The vein is not pulsatile. Who is pulsatile? Artery is pulsatile. Now in our case, the vein is pulsatile. Means what? The pulsatile nature of artery is transferred to the vein. Means what? There should be a connection between artery and vein. That's why the pulsatile nature will be transferred. And this connection is called as fistula. Which fistula? AV fistula. Okay. So answer is AV fistula. Let's learn. The AV fistula is means what? Arterialization of the vein. That is, our vein now become dilated, tortuous and thicken and pulsatile. So pulsatile vein. Most common cause of AV fistula is trauma, which is given in our case. Okay, there is a machinery like murmur. So in the AV fistula we have machinery like murmur, which is recent PYQ. Also, this is a PYQ. There is a Nicol-Donny-Braham sign. What is the Nicol-Donny-Braham sign? This is the bradycardia and hypertension when the artery proximal to the AV fistula is compressed. So these two are PYQ which should be remembered. So note the point. That's why I told you this is not video regarding the just question and answer. It about discussing the most important topics in the surgery which will helpful for your recent examination. Okay, so this is about the AV fistula. Any doubt? Shall we move to the next? Yes. Now it is very simple question. Most common cancer in female in the India, all you know, that is the breast. Earlier it was cervix, but now it is the breast, and lung, you know, in the most common in the adult. Okay. Next question is, the patient was brought to the with recurrent vomiting episode and X-ray is given. What you see in the X-ray, there is one only sign in the X-ray, and this is your single bubble sign, which is seen in the HPS, that is hypertrophic pyrolic stenosis. Due to the stenosis, stomach will be distended, okay, and it will seen like a single bubble sign. And in the HPS we have classical triad, that is the hypokalemia, hypochloremia with metabolic alkalosis and paradoxical aciduria. So this is what we have to remember. This is the classical sign of HPS or classical triad of HPS. So in case we have asked, the answer is hypokalemia again. Now we have to remember now the treatment for the HPS. It is a stricture, okay, it is a obstruction, it is a stenosis. So we have to relieve the stenosis surgically. So the pyrolectomy we should do. The name of this operation is Ramstedt-Friedet pyrolectomy. Okay, so treatment is again a pyrolectomy, that is Ramstedt-Friedet pyrolectomy. Now the question is asked like that, before the surgery, which is treatment option, or we directly go for the surgery. So before surgery you should correct the hypokalemia before the surgery, because hypokalemia is medical emergency and this HPS is not surgical emergency at all, it is a medical emergency. So before the surgery we have to correct the hypokalemia. So question will be asked like that, the first step in the management correcting hypokalemia or pyrolectomy. So first step is correcting hypokalemia, then we should go for the pyrolectomy, which we have to remember. Now this is a single bubble sign, we have double bubble sign, we have triple bubble sign. Okay, we will see later. Okay, 1 minute, we will see that question also the same. So this is identify the cause of given condition. Here we can see 3 bubbles. In the previous case of HPS we can see only one bubble, that is the stomach distend. Here we are seeing the 3 bubbles. So it is a jejunal atresia. So you know that the single bubble sign, that is the gastric outlet obstruction, that is the single bubble sign, which is the HPS. Double bubble sign, you know that the duodenal atresia, and triple bubble sign is jejunal atresia. So we have to remember these 3 signs. Along with that, there is a multiple air fluid level is also there. Okay, the multiple air fluid level, like this I will show. These are the multiple air fluid level you can see, and this is seen in the case of the dilated bowel. Okay, or it can seen in the ileal obstruction. So here case will be the jejunal atresia. Now in this case from the X-ray you can know this is the bowel obstruction. So it is the large bowel obstruction. So remember this single bubble sign, double bubble sign, triple bubble sign and multiple air fluid level about the ileal or large bowel obstruction. Okay, now any problem, we will go to the next question, that is the nerve injury. Okay, the nerve injury is very important because as already we learn about the incision in the various surgery. Okay, then we will learn about the GI2 obstruction, and then we will learning now the various nerve injury in the various surgical operations. Okay, so here in indirect inguinal hernia surgery, which is most commonly injured nerve. For the hernia, we have two way, that is the open hernia surgery. Remember, in the open hernia surgery, iliolinguinal nerve is going to injure. In the laparoscopic hernia surgery, lateral cutaneous nerve of thigh is going to injure. Okay, so this is about hernia. But about the open appendix, in the open appendix surgery, iliohypogastric nerve is going to involve or it is injured. And again, iliohypogastric nerve, it is nerve which is entrapped in the mesh repair. So these are the important points. Here we have asked indirect inguinal hernia, that is the open hernia surgery. So ilioinguinal nerve is going to injure here. Any problem? Any doubt? Now again nerve injury question. During the excision of the ranula along with the sublingual gland, which is structure is likely to be injured? So this is again a lingual nerve. I will tell you, during the excision of ranula, रैनुला का एक्सीजन होगा या सबलिंगुअल ग्लैंड का एक्सीजन होगा या सबमैंडिबुलर ग्लैंड का एक्सीजन होगा. We have to remember that the nerve injury is in lingual nerve. But when there are two ways of excision, excision of ranula होगा, sublingual gland होगा या submandibular gland होगा, we excise to the two way, that is from inside, from the oral cavity, and from outside, from inside, from oral cavity or from outside. Suppose we are incising from the oral cavity, that is from the inside, then lingual nerve is more injured than the hypoglossal nerve. Both are injured, but most common is more involved is lingual nerve. This is from oral approach, from the inside. But we are excision from the outside, then the facial nerve branch, that is the marginal mandibular branch of the facial nerve is going to injure from outside root. We are going from outside root. Then time the marginal mandibular branch of the facial nerve is going to injure. So remember these two root, inside root, oral root and outside root. Okay, now the question sometimes, that is the pre-IQ question, sometimes ask like that, which nerve is not injured during the ranula excision or this submandibular or sublingual gland excision? So this is a glossopharyngeal nerve. This is also we have to remember, which is injured, which is not injured. Okay, any problem in the nerve injury during the surgery? We have to remember all these nerve injury which are important. Okay, now again same question, that is your ranula. Ranula is what? This is ranula is the bluish red cystic swelling on the left side of the floor of mouth. Okay, this is transilluminating and fluctuating, and this is frog belly appearance. This is PYQ, that is the frog belly appearance. We have given the image and we have asked about the diagnosis and treatment. So this is diagnosis is asked. This is a ranula. Any problem? Shall we move to the next? Okay. Now, which is the characteristic sign of the hypovolumic shock? We are knowing that in the hypovolumic shock there is a hypovolemia. Volume is decreased, means that there is a loss of blood or loss of fluid in the hypovolemic shock, due to which the preload is going to decrease, and preload is decreased, that's why cardiac output is going to decrease. And to compensate that preload and cardiac output, our heart try to push faster. There will be the increased heart rate, tachycardia, increased vascular resistance, there will be the vasoconstriction. So this is the scenario in case of the hypovolemic shock. So which of the following characteristic? That is the high vascular resistance. Any problem? Okay, now the next, again we have discussed this, it is the jejunal atresia. Again we have discussed this free air fluid level, that is the bowel obstruction. Now again we have the image given like this. Here you can see the gas under the dome of diaphragm. This is the dome of diaphragm and you are seeing this gas. So this gas under the dome of diaphragm is actually due to the hollow visceral organ perforation. There is a perforation of hollow visceral organ, like your GI tract is a hollow, right? So the perforation of the GI tract or GI ulcer, duodenal ulcer, jejunal ulcer, peptic ulcer, whatever be the ulcers, The perforation of the GI tract or arsal causes the air below the diaphragm, which is called as the pneumoperitoneum, that is air below the air in the peritoneum. This is the pneumoperitoneum. This is the perforation of GI tract or ulcer. Any doubt in this? No? Shall we move to the next? Okay, now it is also an important question for the skin grafting. We have given this image and asked the what type of skin grafting or what type of mesh, in which type it is used. So skin grafting is mainly of two types: split thickness skin graft and full thickness skin graft. Okay, you can see here STSG, that is the split thickness skin grafting and full thickness skin grafting. The split thickness skin grafting is also called as Thiers skin grafting, which is called as Thiers skin grafting. The full thickness skin grafting is called as Wolf's skin grafting. Okay, now this full thickness skin grafting is usually cosmetically better. Okay, that's why this is used for the cosmetic purposes, like on the face you have to do the skin grafting, then we do full thickness, because here mesh is not used. Here in the split thickness skin grafting we use the mesh. We cut the skin like this, we use the mesh, and due to the mesh, this is the crocodile skin is occur. When we use the mesh, skin become our crocodile like. That's why this is cosmetically worst, and we does not use for cosmetic purposes. We use there for the other parts, like dependent part like the buttock or like that. So meshing is done in case of split thickness skin graft. Always remember this. Okay, and the name, other name like Thiers and your old face. Any problem? Shall we move to the next? Okay, so the next question is about a perforation. We have learned about the GI tract obstruction. Now we will learn about the GI tract perforation. The patient was brought to the emergency with a diffuse abdominal pain and abdominal wall rigidity. Laparotomy done, and this is find image is given, and we have asked what is the diagnosis and management. We have asked the management, but first we should able to diagnose the condition. Here this is here this is your large bowel. You can see large bowel. Okay, and here is the perforation. So this is a typical image of the ileal perforation. We have to remember this image. This is typical image of the ileal perforation, ileum perforation. Okay, and for the treatment of ileal perforation is just primary closure with the vicryl sutures, and this primary closure should be done a transverse, not oblique or not okay, so this should be done in the transverse way. This is the primary closure. So answer here, this is ileal perforation. Answer here, simple primary repair. Okay, that is the primary closure. Ileostomy, okay, ileostomy is done for the large bowel perforation, not for the ileal perforation. Okay, so this is again a question. Any doubt? Now again the same GI tract perforation. This image is given, and we have to first diagnose the condition. This is a duodenal perforation. Why? Because you can see here the gallbladder. So this is gallbladder, so this will be duodenal, and there is a perforation, so this is the duodenal perforation, or there is a duodenal ulcer perforation. And what is the treatment? Suppose this is perforation, we look like we just put a patch like this. This is called as a omentum patch repair or Graham omentum patch repair, also called as modified Graham repair. Okay, so this is about the duodenal perforation. So remember this important gastric tract or GI tract perforations. Any problem until now? Okay, shall we move to the next? Okay, now this is case of EDH and SDH. Now the patient is brought to the emergency with the fall history and Bain CT was done, and you have given this image. This typically image of EDH because it is a convex. Okay, so convex is your EDH. Okay, and this EDH is due to mainly the injury to the artery. This is the arterial bleed. Which artery? Middle meningeal artery is bleed here, due to which there is a EDH, and the EDH are like biconvex. Now another image like SDH. SDH is given here again. This SDH are what? Convo concave. This SDH are what? Convo concave. And what should we have to remember about this SDH? EDH and SDH both have same way of presentation. Okay, just location and artery and vein. So this is arterial bleed, EDH. SDH is venous bleed, that is your bridging veins are damaged here, and due to which you give a convex type of bleeding which is seen in the just older age. So this is differentiation we should made in the EDH and SDH. The mechanism or cause for both is same, like fall on the head. Okay, and the treatment for both is again same, that is the craniotomy. But for the EDH, when we should do craniotomy, if there is a midline shift greater than 0.5 centimeter and if this volume is greater than 10 cc, then only we can do craniotomy for both SDH and EDH. And we have to remember this just from the CT image of the brain. So this is the CT image of the brain, EDH craniotomy. Now here also CT image of the brain, here is SDH, and the options are given different, like we have to give here a vitamin K. Why? Because it stopped the bleeding. We have to stop the bleeding. The bridging veins are now damaged, so we have to stop the bleeding from the bridging vein, so we have to give the vitamin K. No any option. Okay, now this is clear about EDH and SDH. Any doubt in this? Shall we move to the next? Okay, the next is your RTA patient and it present with the subcutaneous emphysema. There is no air entry on the right side, vitals are unstable. What is your immediate management? To know the management, we should first diagnose the case. Okay, so there is no air entry means what? Their lungs are collapsed on the right side. Right side को air entry नहीं है, मतलब क्या है? Right side की lung ये क्या है? Collapse है. There is RTA, so RTA होगा तो might be there is a rib fracture, and due to the rib fracture there will be the right side of the lungs will be collapsed. So this is diagnosis. What is your diagnosis? Diagnosis is here pneumothorax, that is the tension pneumothorax. So रिब फ्रैक्चर होगा आरटीए की वजह से, उसके वजह से लंग कोलैप्स होगा, टेंशन न्यूमोथोरैक्स होगा, उसके वजह से एम्फेजेमा होगा, उसके वजह से नो एयर एंट्री ऑन दैट साइड होगा. एनी डाउट? सो नाउ वी हैव टू गो फॉर द इमीडिएट मैनेजमेंट ऑफ द टेंशन न्यूमोथोरैक्स. सो टेंशन न्यूमोथोरैक्स में भी दो टाइप है. अभी पेशेंट के वाइटल स्टेबल होंगे तो मैनेजमेंट इमीडिएट इज आईसीडी इंसर्शन. इफ पेशेंट के वाइटल्स अनस्टेबल होंगे so we have to do a needle thoracostomy. So in our case the vitals are unstable, so we can't insert ICD, we have to go for the needle thoracostomy. Okay, now the needle thoracostomy in the adult, at which place needle thoracostomy? In the fifth intercostal. In the pediatric, which space? That is the second intercostal. So in this case we have asked a adult patient. If there is no mention, you consider adult, because if there is pediatric patient there is mention like that. So vital are unstable, adult patient is there, so insertion of the wide bore needle, that is your thoracotomy, insertion of wide bore needle in the fifth intercostal space at the upper border of the lower limb in the ICD triangle in anterior axillary line. So we have to remember this, because this is the mainstay immediate treatment. वाइड बोर नीडल इंसर्ट करनी है फिफ्थ इंटरकोस्टल पेस में एट द अपर बॉर्डर ऑफ लोअर रिब इन आईसीडी ट्रायंगल इन एंटीरियर एक्सिलरी लाइन इन केस ऑफ द एडल्ट. इफ देयर इज पेडियाट्रिक पेशेंट you should do the thoracotomy in the wide bore needle insertion in the second intercostal space at the mid clavicular line. So this is about the pediatric patient. So any doubt? So we have to go like that. टेंशन निमोथोरैक्स उसमें दो है, वाइटल स्टेबल हो गया तो आईसीडी, अनस्टेबल होते के थोरैकोस्टोमी. थोरैकोस्टोमी में दो है, पेडियाट्रिक पेशेंट सेकंड इंटरकोस्टल स्पेस, इफ एडल्ट पेशेंट फिफ्थ इंटरकोस्टल स्पेस. एनी डाउट? नो? शैल वी मूव टू द नेक्स्ट? ओके, नाउ अगेन अ जीआईटी क्वेश्चन. द ब्रोंकोस्कोपी के लिए पेशेंट लाया है एंड ड्यूरिंग द प्रोसीजर देयर इज अ परफोरेशन एट 25 सेंटीमीटर फ्रॉम द अपर इंसाइजर. I have told you the mnemonic regarding that in my recent lectures on the surgery, that is the BALD mnemonic, which is we have to remember the structures and their distance from the upper incisor. At the 15 centimeter from the upper incisor we have the cricopharynx, and cricopharynx is what? The beginning of your esophagus. So this is the B, BALD means a B. beginning of esophagus, that is your cricopharynx, at 15 centimeter. At 25 centimeter we have arch of aorta and left bronchus, that is your A and L in the bald, arch of aorta and left bronchus. At the 40 centimeter we have the diaphragm, that is the D. So this is the bald mnemonic we have to remember. And here arch is 25 centimeters, so arch of aorta. That not right bronchus, it is left bronchus at the 25 centimeters. Okay, any problem? No doubt? Shall we move to the next? Remember this mnemonic bald. Now here a lady presented to the OPD after 10 days after delivery, means what? Postpartum. This is the postpartum lady. Chief complaint of breast tenderness, fever and cracked nipple. These are the typical triad: breast tenderness, high grade fever, cracked nipple. This is typical triad of breast abscess, you know. So likely diagnosis is breast abscess. There is breast engorgement, pus collection, and which is most common microorganism responsible for that? That is your Staph aureus. What is the drug of choice for that? This is the cloxacillin or dicloxacillin. Any problem? Any doubt? No? Shall we move to the next? Not a mastitis. Now the thyroid. The patient come to the OPD with the chief complaint of swelling in the thyroid region. The same question is asked in the UPSC CMS in other way. So upcoming I will upload the video on UPSC CMS PYQ also, which are very important also, and they are the standard PYQ. We have to very helpful in the NEET PG examination also. So in their UPSC CMS also we have asked the same question in the different way. So we have to learn that also. So subscribe our channel so that you can get the videos. Shortly we will upload the video of UPSC CMS exam surgery question. Okay. Now the patient come to the OPD with a chief complaint of the swelling in the thyroid region, which moves with the degglutination and protrusion of the tongue, and there is a rupture of swelling with the discharge of pus. What is the treatment? So first we have to diagnose the condition, then we have to go to the treatment. So there is what? The swelling move with the degglutination. Swelling is in the thyroid region and swelling move with the protrusion at the tongue. So first of all we should know that the which swellings moves with the degglutination. The thyroid is moves with the degglutination. Subhyoid bursa moves with the degglutination. Thyroglossal cyst moves with degglutination. But we have given one point extra that also moves with the tongue, and this moves with the tongue is your thyroglossal cyst, because it is attached to the base of the tongue. That's why the thyroglossal cyst is our diagnosis. And now we have to go for the management of the thyroglossal cyst. And which operation is done? You know that the cyst trunk operation is done, in which your thyroglossal cyst is removed, the body of hyoid is removed, and complete tract up to the base of the trunk, base of the tongue is removed. That is your what? Cyst trunk operation. Okay. This thyroglossal cyst, if not managed, it will convert to the thyroglossal fistula, and this thyroglossal fistula increases the risk of papillary carcinoma of thyroid, not a squamous carcinoma. This question is asked: papilloma or thyroid? Papilloma papillary or squamous? It is the papillary carcinoma. That's why I have written here. So note down that's important point. These are the previous year question. Okay. This is any problem in the thyroglossal cyst. So before the managing the patient, we should able to diagnose the condition, and then we will go for the management part. Now this is also typical. We have given this image and we have to identify the ulcer. So from this image what you can know, the ages of this ulcer are very chronic. Okay, these are not newly, they are fibrous, and there is some granulation tissue also present here. There is no pus discharge and there is no any recent sign of infection. So this is a tropic ulcer, typical image of tropic ulcer. These tropic ulcer are present at the pressure point, like here also present, here also present, here also present, here also present. At the pressure point these tropic ulcers are present. And the tropic ulcer, now there are two type of ulcer, a tropic ulcer and tropic ulcer. There is difference of just a tropic ulcer is are the ischemic ulcer, and tropic ulcer are neuropathic ulcer. These are painless ulcer which are present at the pressure point. So diagnosis is again a tropic ulcer. What is about the arterial ulcer? Arterial ulcer are not present at the pressure point. They are present at the tip like this, here, 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 here. They are shiny and they have the thin skin, and they are also a painless, but they are present at the tip. This is about arterial. What is about the venous ulcer? Venous ulcer are like this in the region. These are the pigmented ulcer. There is a lipodermatosclerosis present in the venous ulcer, and there is varicose vein associated with these venous ulcers. Okay. Now what are the diabetic ulcer? Diabetic ulcer, you are knowing that there is a typical history of the DM, and there is a pus, there is an infection like that, then we can diagnose the diabetic ulcer. So this is about the ulcer. So remember all four ulcers, which are very helpful, because the questions are made from this only. Like here ask tropic ulcer, next time we'll ask arterial ulcer, next time we'll ask diabetic ulcer. So we have to watch this video carefully. Shall we move to the next? Here the question is asked about your diagnosis and next investigation. So this is leukoplakia or erythroplakia. This is the erythroplakia because it is rare. In the UPSC CMS exam 2024, we have question asked about the leukoplakia. So like that similar question asked in the every exam. So this is a erythroplakia. Leukoplakia is white patch. Okay. Now for the managing, what is the investigation? Next investigation, we have to just observe or do the biopsy. We have to do biopsy because this is the very malignant condition. Erythroplakia, that is the reddish mucosal plaques, it has high risk of malignancy. That's why we have to do the biopsy for the confirmation. So answer here is erythroplakia and biopsy. Any doubt? Shall we move to the next? Now here a testicular tumor, we have to remember all the four testicular tumor most characteristic feature. Patient come to the OPD with the complaint of mass in the testes. Orchidectomy performed. This is image of orchidectomy. And what is the best prognosis? This young patient. Okay, actually this is the image of seminoma, but we have to give on this image, but answer is not seminoma here, because here we have given the young patient. Now we have to remember that out of the four testicular cancer, seminoma has the best prognosis in the adult. We have given here young patient. The yolk sac tumor has a best prognosis in young or children. That's why young, why yolk sac. So here answer will be the yolk sac tumor because it has best prognosis in the children. Seminoma is best prognosis in the adult, and Leydig cell tumor, it has best prognosis when it is benign. सो बिनाइन में लेडिक सेल को बेस्ट प्रोग्नोसिस है, चिल्ड्रन में योक सैक ट्यूमर को बेस्ट प्रोग्नोसिस है, एडल्ट में सेमिनोमा को बेस्ट प्रोग्नोसिस है. Okay, so this is typical image of seminoma. And also the PYQ, in the PYQ topics we have asked about the inclusion bodies in the testicular tumor. So what is the inclusion body in the yolk sac tumor? We have Schiller dual body, which is the inclusion body in the yolk sac tumor. What is the inclusion body in the Leydig sac tumor? In the Leydig cell tumor we have Rinke crystals as a inclusion body. So this important inclusion body we have to remember. Okay, so any doubt from the testicular tumor? These are the important points regarding the testicular tumor. Okay, so almost from the one question we are covering 5 to 6. Okay, this image one question, this one question, 3, 1, 2, 3, 4, 5, 6. From the one question we are dealing with the 6 questions. So this is high yield session. We have to attend all PYQ session. Okay, we have to watch the all PYQ videos, because I am going to tell you the all the information related to that topic, not just covering that PYQ. Okay, now again for the pilonidal sinus we have 2 questions. The patient underwent the surgery and which type of flap is used in this surgery. So first of all, remember the various flap used in the pilonidal sinus. So we have Limburg flap, we have Caridrakis flap, we have rhomboid flap, we have axial flap, we have bilobe or leaf flap, we have Boscon method, we have Zildplasty method. These are all the flap and methods used for the pilonidal sinus. So we are given this image and we have asked specifically this flap. So this flap is again bilobe flap, which is look like a maple leaf. So this is also called as a leaf flap. You can see here This is your pilonidal sinus. Okay, one minute. This is your pilonidal sinus and this is a leaf flap. So we are getting this flap and we are just covering this like. So this is a bilobe flap, both lobe are there. Okay, so this is a bilobe flap which is for the your pilonidal sinus. Next, also given image and we have asked this flap. So this is a what, a rhomboid flap, which is also called as Limburg flap, which is also called as a transposition. Why transposition? Because we are seeing that we are taking the flap like this and then we are covering like this. So these are the transposition or rhomboid or Limburg. These are two typical image which asked in the every exam for the flap used in pilonidal sinus. Any doubt? Shall we move to the next? This is again from the burn. We have a burn patient in the casualty and it has burn on the left and right upper limb, anterior chest and abdomen, and we have to calculate the percentage. So just forgot about the question. We have the Wallace rule to calculate the surface area of the burn, which we have to remember. So what is the Wallace rule? Wallace rule for adult is different. Wallace rule for pediatric patient is different. In the adults Wallace rule, we have head, that is the front and back, both side of head have 9%, both whole the back has 80%, whole chest abdomen has 80%, right arm has 9%, left arm has 9%, perineum has 1%, right leg 80%, left leg 80%, which make 100%. What is difference in the pediatric and adult? In the adult we have head and neck 9%, but in the pediatric we have head and neck, that is your 80%. Head is given more importance here. Again rest of the same, abdomen chest is 80, back is 80, right arm 9, left arm 9, and perineum is 1. So this extra 9% are deducted from this. Right leg 30.5, left leg 13.5. Here is 80%. So here 13.5, 13.5, 4.5 reducted and it is increased in the head and head region. So 80% head. Here is 9% head. This is a Wallace rule for calculating the surface area in case of burn patient. Why this Wallace rule is important? Because in the management of the burn patient, we have to calculate also the fluid, how much fluid we should give to the patient in initial 24 hours. So to calculate this, how much fluid given, we have to first calculate how much surface area of this person is burn. So from this Wallace rule, we can calculate the your fluid requirement. For the fluid requirement, we have the Parker formula of the fluid requirement. And what is this Parker formula? 4 ml into percentage of body surface into the weight of the patient. And suppose from calculating this, you calculate the 5 liter of the fluid we have to give to the patient in initial 24 hours. So the manner of fluid, it is very important. How you are giving this 5 liter? Directly we are giving 5 liter, or we are just giving, in which way? So out of this all, what the requirement, we have to give in the first 8 hour, half of the fluid we have to give. Means if 5 liter are required, 2.5 are given in the first 8 hour, and rest half, that is less 2.5 liter, is given in the next 60 hour. So total in the 24 hour we have to give 5 liter. This is just for example. Whatever the requirement, the half of given in the first 8 hour and next half are given in the next 16 hour. So this is total 24 hour fluid which we have to give in the burn patient, and this is calculated from the Wallace rule, and we have to calculate this fluid requirement also. This is also the PYQ. So now question asked here, what we have just asked the calculations of the surface area. We have asked the left and right upper limb. So 9, 9, 80, and chest and abdomen 80, 80, 80, 36. This is your 36. But we have these two important point which we have to remember. Again from the burn, this is only the question which asked in the any examination. Apart from this, no other question is asked in the burn section. So it is very important. Okay, any problem, any doubt in this? Shall we move to the next? Now in the next, we have seen the hernia. Okay, which of the following is correct regarding patient as shown in the image? So in the UPSC CMS exam also there is a hernia, but this hernia is paraumbilical hernia is asked. Here we have asked the umbilical hernia. So this is typical image of the umbilical hernia. So for the management in the umbilical hernia, for the small umbilical hernia we do the primary closure and we do the rectus overlap for the small umbilical hernia. For the large one, this is your large umbilical hernia. What is the treatment of large umbilical hernia? We have to do the mesh repair and we have to remove all prolapse content. So what is the treatment? The mass should be reducted, the mesh repair should be done, and reductant skin should be excised. So this is the main treatment for the large umbilical hernia. If there is small umbilical hernia, we just do the primary closure with the rectus overlap. Okay, so this is the answer. Any problem? We have to remove all this mass and we have to do the mesh repair. Any doubt regarding the treatment of umbilical hernia? No. Shall we move to the next? Now these are the questions. We don't know options regarding this question, so just we are discussing that. The adjuvant drug given in the gist, that is we know imatinib. Already we have discussed this topic. The treat the ileal perforation, we have to do the resuscitation. Now ileal, for the ileal we have to do exploratory laparotomy and primary closure, just in the primary closure in the transfer direction using your vicryl sutures. Now the 5-HIAA level pellagra like skin, and we have to ask about the diagnosis. We know that this is the carcinoid, and in the carcinoid we have to remember the 5-HIAA level is increased, the serotonin level is increased, and histamine level is increased, and due to this increased histamine level we can get a bronchospasm. So these are the typical words which are used in the case. If 5-HIA level is increased, if serotonin level is increased, if histamine level is increased, if patient has bronchospasm, then absolutely this diagnosis is carcinoid. Suppose if serotonin is increased, there will be the pain in the abdomen, there will be the tumor in the ileum and pancreas. It will typical words are given in your case in case of increase in the serotonin. So this is again diagnosis again goes to the carcinoid. Okay, these questions are mostly repeated in this FMGE also, 22 also, 14 also. So these are very important again about the carcinoid, that is 5-HIA level, serotonin level, histamine level, tumor in ileum, pancreas, abdominal pain, bronchospasm. These are the typical words. Okay, now the next is we have about the neck dissection. Now the neck dissection is of two types, that is a radical neck dissection and a modified radical neck dissection, that is MRDN. What is done in the radical neck dissection? We remove level 1 to 5 load. All the lymph node of level 1 to 5 are removed in the radical neck dissection. We remove the spinal accessory nerve. We remove the internal jugular vein. We remove the sternocleidomastoid muscle, and also there is a submandibular salivary gland removal, but this is optional. So these four things are removed in the radical neck dissection. What is modified radical neck dissection? If one of them is not removed, then we modify this neck dissection. That's why we call it as a modified neck dissection. That is the modified radical neck dissection. There are three types, 1, 2, 3. In the one, we preserve the spinal accessory nerve. Okay, in the one we preserve the spinal accessory nerve. In the two we preserve the internal jugular vein, and in the three we preserve the sternocomastoid muscles. So this is mnemonic is sister. Yes, we in the one we preserve spinal accessory nerve. I in the second we preserve internal jugular vein. ST in the third we preserve the sternocomastoid muscles. So this is a modified radical neck dissection. So now from the neck dissection, whatever the question may be asked, these are from only this topic. Okay, I exactly don't know the question how it is asked, that's why I have given all the information regarding radical neck dissection and modified radical neck dissection. So this is one question regarding this, and it is frequently asked PYQ, not apart from this. Okay, so just remember this, you will be done with it. Now again we have the case of Boreau syndrome. I don't know exact question and option, that's why, but there is a history of binge alcoholic, there is a history of chest pain, mediastinitis, and there is a surgical emphysema, having a history of the vomiting, and there is also air leak in the mediastinum due to the ruptures, and this is a classical sign. All are the classical sign of this Borehouse syndrome. You have a classical history of binge alcoholic person. Okay, any doubt in this? Okay, now next again the image of liver, I think it is given, and we have asked about the segments. So just this is a conoid classification of the anatomical liver segment, and these segments are classified into the left and right lobe by the line which is called as a canteen lines, not a canteen line, it is cantile lines. Okay, so now the name are given in the clockwise direction, like 2, 3, 4, 5, 6, 7 and 8. This 4 is divided into A and B, 4A and 4B, and behind this 4A we have the first lobe behind the 4A, which is called as a caudate lobe, and the typical feature of this lobe is it takes the supply from both side of portal vein, right and left, and it drain into the IVC. So this is about the conoid classification, cantile line dividing into the left and right, and this is in the clockwise direction. We have to name the segments. Okay, the inferior segment, superior segment, right lobe, left lobe, posteriorly, anteriorly, medially and laterally. These are the segments. Okay, no problem. These segments are divided into the IVC and falciparum ligament. IVC from behind, falciparum ligament from front, and this cantile line. So this is typical anatomy we have to remember about this segment of the liver. Any problem in this? No? Shall we move to the next? Okay. Now the flask shaped ulcers are asked, and this is, these are the amoeboic ulcer. These are the flask shaped ulcer. Now again flower wash sign which is seen in the horseshoe kidney on the IBP. So this is again asked. Now for the mesh repair, we have asked the question. I exactly don't know, but I will tell you about the mesh repair. Apart from this you will not get any question. So suppose this is your rectus muscles, both are your rectus muscle. This is the anterior rectus sheet, this is the posterior rectus sheet, and this is your peritoneum. Okay, now if mesh is placed behind this anterior rectus sheet, here this is green color mesh, so this is called as a onlay mesh. If mesh is placed between these two rectus muscles, this is your violet color mesh, this is a inlay mesh. Okay, now if the mesh are in between this rectus muscle and posterior rectus sheet, but anterior to the posterior rectus muscle, that is anterior to posterior rectus muscle, if this is the mesh, that is called as a sublay mesh. If the mesh is posterior to the posterior rectus sheet, if it is this is posterior rectus sheet, posterior to posterior rectus sheet, this is the underlay mesh. So we have to remember onlay, inlay, sublay and underlay. Apart from this we are not asked any question. And this is your again third type, that is IPOM. If mesh is placed posterior to the peritoneum, that is the intraperitoneal onlay mesh. So these are the 5 type of mesh we have to remember for your examination. Okay, and now this end with the discussion of the surgery recall of the FMGE questions. So go through it, watch it, take down notes, take down topic, and also subscribe to our channel because we are uploading soon the UPSC CMS exam recall, which will also very helpful for your NEET PG examination or FMG examination.